Chamara. Next lecturer is Dr. Narada Kadituakku. He's a consultant cardiologist attached to District General Hospital, Vavuniya. Today he will speak to us on patient presenting with acute dyspnea. Over to you, Narada.
Evaluation of chest pain is a very important topic in medicine because a lot of patients come to us with chest pain. As nurses who are working in cardiology, in relation to cardiology wards, we get a lot of patients with chest pain coming to us. It is pretty important to evaluate them, to differentiate them between a sincere cause or a life-threatening cause from a not very important cause. The first key message, a general rule, is to consider a very serious cause as the possible cause for chest pain. So even if you miss the diagnosis, then you have excluded the possible serious causes. So always don't take chest pain lightly, take it pretty seriously, and always think ischemia or reduced blood supply to your organ as a possible cause for the chest pain. Any pain, when we evaluate, we think about the site of pain, onset, radiation, progression, aggravating factors, relieving factors, and the associated symptoms. So that is the usual way we evaluate a chest pain. So we apply the same thing to the chest pain. So the pain could arise from the retrosternal area, it means behind the sternum. Then the possible causes you should keep in mind are a heart attack, and it could be gastroesophageal reflux disease, you usually call as gastritis, and as other serious problems like aortic dissection and pulmonary embolism could also come in that position. The intrascapular pain, that is the back pain. Sometimes people have chest pain with back pain. You should always consider ischemia, and the other problems could be from the gallbladder and pancreas, but you always should suspect ischemia, especially in those intrascapular pain. You should keep in the mind the possibility of aortic dissection. Then the right lower anterior chest pain is usually coming from the abdominal pathologies, but still you should consider a heart attack or a possible sincere cause. Same apply to the epigastric pain and the lower anterior chest pain. The epigastric pain is usually misdiagnosed as abdominal pain, and very serious problems from the heart like myocardial infarction, aortic dissection, and those things are missed thinking the pathology in the abdomen. So you should always remember that epigastric pain also could contribute to a possible cardiac causes. The shoulder pain and arm pain, those when the patient complain pain there, even though it's closest to the chest, it's very important because heart attacks and especially the disease called pericarditis, you can have the pain. I have seen patients who only complain pain in the arm for heart attack as a referred pain. So you should always take the arm pain very seriously as well. It is pretty important to understand what is typical anginal pain. So you should always know what is typical anginal pain. It is a pressure type of a pain which usually start a duration about 2 minutes, and when you walk, when you exercise with the excitement, patient get the pain, and it might radiate to the arm or the jaw. If it is radiated jaw, it's a very serious thing. Usually the proximal LAD lesions give that kind of angina, and it usually don't change with the respiration, the position, and patient have sweating, nausea, usually with this pain, and rest and GTN will relieve the pain. If those features are not there, then it's a atypical chest pain. Right. The chest pain could be from heart. When you call the cardiac chest pain, there are two major divisions. One is from the coronary arteries. Those are stable angina, unstable angina, heart attack, and the pains, even though not coming directly from the heart, could be related to the heart, like aortic dissection, pulmonary embolism, pulmonary hypertension, pericardial disease, aortic stenosis, heart failure, and cocaine. So we'll talk about the typical myocardial heart attack pain. They have a pressure type of severe pain. It's gradually increased, and they have radiation to the back or the arm, and they have severe sweating. So if they're sweating, you should take it pretty seriously, and the patient also could have nausea, shortness of breathing with this problem. The important thing is what the context. If an elderly patient who was a smoker, diabetes, hypertension, dyslipidemia, previous heart attack, if they complain chest pain, or with the family history, you have to take very seriously. This is the typical features of a heart attack. The heart attack different from angina. The angina, the pain duration is less than 20 minutes. If the pain continues more than 20 minutes, you should take it as a heart attack or an ischemic cause, and patient should admit to the hospital. Pulmonary embolism. This is also a very important cause, which important cause for chest pain in hospital. Unfortunately, we miss the diagnosis because the pain is usually subtle and pain is a bit atypical. So the important things to remember are the context of chest pain. If a patient who has been in the ward for long duration of time suddenly complain of chest pain, then you should think the possibility of pulmonary embolism. Pulmonary embolism, what happens is there are blood clots form in the leg, and they travel to the veins and go to the lungs and block the lungs. So the patient might have swollen legs, and patient might complain chest pain and shortness of breathing. So then you should consider the possibility of pulmonary embolism, and you should alert your senior medical officer regarding that. So the other important thing is the dyspnea. Usually they have difficulty in breathing associated with chest pain. And the important thing is the context of the history. The other two important diagnoses I want to talk are the aortic dissection. Aortic dissection is a very important diagnosis not to miss, because they have very classical history. In that, what they have is, they have very sudden onset of Tabin type chest pain, and that pain radiates to the back, and it migrates along the back with the aortic dissection, right? So the patient has severe chest pain, you should consider the possibility of aortic dissection, and you should always, because they come with inferior MI. So if the patient is inferior MI, if they have undue chest pain, then you should always entertain the possibility of aortic dissection. There are a few things you can do if you suspect aortic dissection. You can auscultate for aortic regurgitation murmur. That is not practical for the nurses, but I would suggest to check the blood pressure in both arms. If there's a significant difference in the blood pressure of both arms, then there's a possibility of aortic dissection, where you can alert your seniors about the possibility of aortic dissection, and you might save a patient's life. The other classical chest pain histories, they are with pericardial disease. Pericardial disease, what they get is a very sharp chest pain, and it's provoked by the respiration. So when they breathe in, they will feel pain. So they will take very light breaths. And that pain is very classical, it's very sharp and provoked by respiration. It will radiate to the patient's shoulders. And the classical thing is, when the patient bends forward, the pain will be relieved, and so usually the patient take that awkward posture. So it's very important to suspect pericardial disease, and it's pretty easy to treat as well. So Chest pain is a very common, in summary, chest pain is a very common complaint, and as nurses who are doing cardiology, you should have a very good idea about the history, because arranging the investigation and those things can be done with the help of the medical officer. But if the patient is having chest pain, from your point of view, take a ECG and evaluate the chest pain and talk with the medical officer. That should be the way. But if the patient with chest pain having is in a poorly condition, then you should start the life-saving procedures as well with airway, breathing, circulation. It is very important not to miss acute coronary syndrome as a possible diagnosis, not to miss aortic dissection and the pulmonary embolism, because those things will endanger the patient's life. So other important thing is always communicate with your seniors, communicate with your colleagues, and if there's a serious problem, straight away go to the consultant and let the consultant know what is going on. So I think that should be the way, and that what you should have to do in case of an emergency. So I think for the nurses, it's pretty important, the history part and the interpretation of the ECGs and arranging further tests should be done by a medical officer. So it is pretty important. The nurses are the first contact of patient. So you quickly evaluate the chest pain. If the patient is having serious problem, the patient may be having short of breath and they are sweating, then you know the things are not good, and straight away shout and ask for help and act according to your protocols in your system. If there's any question, you can ask me after this lecture.
Thank you, Narada. I'm sorry about the little bit of confusion about the topic. Anyway, I hope your knowledge about chest pain, evaluation of chest pain expanded by that. Let me introduce our next